Thank you for joining us today. Appreciate it. I'm James Mansfield with Analytics for Living, and we have an exciting session here to discuss surgical capacity planning in COVID era using artificial intelligence. So very exciting topic here, and thank you all for participating. Feel free throughout, if you have any questions, send them through the chat. And after we finish the recording, if there's any other questions, I'll stay online to answer additional questions. So thanks again. Again, surgical capacity planning in the COVID era using artificial intelligence. Perfect. So our objective is to review and discuss how machine learning and artificial intelligence can better plan surgical capacity in COVID era with Analytics for Living services. So, and first, let's start with a disclosure. The views of this presentation today are those of mine and not from any other prior client or any prior company. And now that's out of the way, let's get started. So we're going to run through a quick introduction. I'm going to talk about the impact of surgical capacity due to COVID, what the problem statement is, and then discuss some of the initiatives that have already been underway and question whether or not they are sufficient. Then we'll jump into the approach where we can employ machine learning, AI, and real-time cloud computing to optimize surgical capacity, and then finish off with a review of services and discuss any next steps. So let's jump in. All right. So for me, I'm James Mansfield. I have responsibility for Analytics for Living, where we apply machine learning and artificial intelligence to improve health, innovation, technology growth, and financial sustainability. And I am also a lead consultant helping Data Prime to expand their life science footprint. And I have 25 years of life science experience, also consumer packaged goods, financial services, and most recently coming from Merck and GSK. Not on the call today, but participating in spirit is Tyler Roth. Tyler comes from Data Prime, and she leads talent acquisition. Comes with great experience at U.S. government and Amazon and Comcast. So thanks for participating virtually here, Tyler, today. And the reason why we have this partnership is certainly when you have solutions that we provide for ML or AI, you may need talent, right, to support that. And that's where the partnership with Data Prime is, where we can pull staff in to accordingly support that on an ongoing basis. Great. So let's talk about COVID impact to surgical capacity. Try that again. Let's talk about COVID impact to surgical capacity. So in the UK, roughly, if we look at just a few different surgeries, but in this one, I'm picking out a really good study that was done to look at head and neck cancers for patients that were requiring surgery. So these are patients that had head and neck cancer. They needed surgery. What happened to them? And what we found was that 28% were delayed. Right, 10% had radiotherapy instead of surgery, and 12% were de-escalating, meaning they didn't get the surgery. Right, so definitely significant impact to those patients. Right, in the U.S., overall, there was roughly about a 35% decrease in surgical volumes back in the 2020 timeframe, and that ranged all the way down to 60%, but it was roughly on average about 35%, which is quite significant. Right? Worldwide, and including the EU, has a study that quotes roughly about 75 to 90% of surgeries were not completed, meaning there were fewer, meaning they just weren't completed. So the takeaway then on this that we're saying is that the surgeries that declined, but those that were able to have surgery and were able to get in, it was significantly delayed, and that it impacted their health, right? It negatively impacted their health. So on the right, we see here kind of some COVID procedures of emergent procedures and other procedures that are happening for patients and so forth, but definitely taking over kind of the operating room and also the whole hospital, right? So in the interim of this, right, when surgical capacity was going down into the pandemic, how did hospitals respond? Well, they expanded by expanding surgical capacity, and that was one. Well, what were some of those approaches? So you may have heard the term backlog, right? So health systems created a backlog of surgeries with lists of people and waiting lists and so forth. And many health systems implemented this, including a criterion saying, including the CDC here in the US, right, said, well, if you have, and then it went down to state level and then hospital level, say, if you have this type of surgery, well, you're not going to get it, right? If you have this surgery, it has to be the XYZ, severity. So that happened, not only in the US, but around the globe. Adaptation is the next piece. So hospitals adapted the hospital to surgical areas and COVID areas. So you'd see a fair bit of hospitals where they had some hospitals that were only COVID patients, other hospitals were kind of walled off. Some parts of the hospital were adapted to enable surgeries as well within the inpatient, right? But the capacity was still kind of limited to just those emergent, right? And then I'm calling the next one expansion, right? So expansion in this case, more surgeries moved out of the hospital into ambulatory care and to outpatient centers, right? That trend's always been continuing where surgeries where instead of going outpatient to, surgery centers and ambulatory care, that trend was continuing. I think it was roughly about 10% growth is what IQVIA was quoting before. So that's kind of, and Health Verity as well. So that they were some of the estimates that were happening, but now a lot more surgeries are pushed down. So, and additionally, the typical inpatient procedures, right, really significant surgeries were moved to ambulatory care or outpatient, right? So that whole kind of care diagram was kind of pushed more to the outpatient, right? So the takeaway on this is that capacity redirection, right, was a quick plug, right, or a Band-Aid, for lack of a better description, right? But it's really not sufficient to sustain future waves, right? With the variants and so forth, what's going to happen, right, with those, and how can that be sustained? Even though there's more capacity, is it being optimized, right? Like if you think about a hospital, it runs 24/7, right? But is our surgery centers or other places that are adapted to accommodate, are they running 24/7? They're not, right? Is there opportunities for that? Probably, but how do you get there? Because there's just more or less a quick kind of, hey, let's stand up a surgery center, or let's move all these procedures to a surgery center, an outpatient, or an ambulatory center. But the takeaway I'm trying to say here is that capacity redirection, it's a plug. It's not going to be sufficient, for suture waves. Given the current environment. So in the pictorials here on the right, you have the outpatient center there on the right. You have a patient and probably got some surgery at more of the outpatient coming out, and then the bottom is more a pictorial of a typical inpatient procedure is now done through outpatient as well. So let's jump into what the impact was to hospitals. Well, the revenue impact with surgical capacity expansion initiated, right? So let's step back and say, well, what was the initial impact of for hospitals, right, overall? So in the U.S., there's roughly, McKinsey was quoting roughly about $200 billion hospital financial losses. That's $200 billion, right? So for hospitals, we're already kind of with thin margins, very thin. Right now, they have losses because typically a lot of the procedures, the revenues that they can bill, the hospitals will bill off the procedure. So if someone's an inpatient and they have a surgery or procedure, they can bill on that. But if someone's sitting in the hospital, with COVID or an event or things they had, there's no revenues there. And if they can't run surgeries, they really can't kind of make that difference, right, to kind of make it work. So essentially, you had roughly about a $200 billion hospital financial loss, right? In the EU, the healthcare system was quoted, right? There's a lot of, really disturbing, estimates there, but it really left the most vulnerable without even healthcare, right? And millions with no care. So essentially, when the healthcare shut down and said, hey, you're not allowed here, they moved into other places. They picked that, other areas for COVID patients, other areas for sometimes emergency areas, and where those are the typical care for, say, the vulnerable, and the most vulnerable had no care at all. Asia Pac, right? Asia Pacific region, roughly 40 to 50% shifted to wellness of staff. So the hospital essentially said, hey, we can't even run surgeries, right? But we're going to focus on the wellness of staff, giving PPE and others. So they redirected their budget so they can have some staff to actually provide some emergent care related to COVID, right? So kind of definitely, was a good direction, but, versus providing care of surgery, right? And then some other quotes, South Korea and Thailand, South Korea has a great healthcare, system there with HERA and a lot of data. And they were seeing roughly 40 to 60% decrease in procedure revenues, right? So you'd see kind of that much significant. And Latin America, the region, and all the governments in Latin America, because it's very typically like a public system is roughly covers about 90% of the system, 90% of the population in Latin America. There are regional shortfalls in funding, right? And when they said, hey, let's expand service or let's go back, right? There wasn't the budget there. There's the inability, they have the inability to kind of even restart healthcare services and enable access, right? So the takeaway here is that the hospitals were already, were in the red. They were put in the red, right, which is unfortunate. And they couldn't get back. They can't even get back yet because they're in the red still. So they need to invest back to adapt things. And then patients that, needed care and needed to get care were left without, right? And they had no place, right? And barely any place to go for emergent or semi-urgent elective surgery, as we see in the EU, where patients that were the most vulnerable, right, weren't even get any even emergency care. So definitely significant challenges. So this is just a pictorial of a big hospital here, hospital floor that's there, and then also around the, the impact on the revenue. So revenue impact was significant for a hospital. Right? So what can be done? Right. So, where we believe at Analytics for Living is that it's a perfect opportunity for, and it may not be the ultimate fix, right? But at least that we think that it's a good way to kind of optimize, right? So, and by employing machine learning, artificial intelligence, real-time computing, right, to optimize surgical capacity. That's kind of the approach we think is definitely a fit here. And it's been done before, and it does work in many other areas. We have done that. We've done that, and we worked with many other clients there. But I think if we start on the left, right, the process steps, and on the right are kind of more of the data steps that's here on the left. But what we mean by employing is this would be first step in here. That first bullet is evaluate and update the hospital capacity volumes, right? If there's a system that now has a hospital and an ambulatory care and outpatient, a surgery center. Okay, let's wrap it all into one and count the hospital beds, right? What is it? How much is there, right? And then the next step would be continued prioritization of surgery. So what's the most severe, right? And also what goes in ambulatory or outpatient, right? That kind of needs to be kind of the governance around that piece, right? And then implement once you have that data, right? You prioritize, working back for that, you have a priority list of surgeries, how many patients you have, you have all the system, right? And then you have at least the volumes, right, of beds and hospitals and so forth. Then you can run a model and say, okay, well, let's simulate kind of surgery capacity, right? Let's take all the data that was happening before, let's run the backlog through and see kind of where the capacity is and see what the gap is, right? And potentially the prioritization may need to change slightly, right? Depending on severity or so forth, but at least in advance before saying, hey, we just can't fit anyone and everyone's overworked and upset and so forth. And it's just, not a win-win overall, right? But it would definitely be the first step, right? To run that model and see kind of what the benchmark is. Once you have that model, would be implement real-time capacity, machine learning, AI with a visualization, cloud-based scorecards, right? The great thing is this technology exists. You have, Google Cloud where AnalyticsforLiving is on. We're also piloting on AWS, Amazon web services as well, right? They exist, right? We can stand up the data, load in the data, run the models, and boom, it's on your phone, right? You can say, okay, how many surgeries at this hospital tomorrow, can we fit, right? And hey, let me call these patients and tell them one needs to go to ambulatory, one needs to go to outpatient, one needs to go to another hospital, let get that done. And it has to be kind of this almost a change, right? It's a bit of change management, of where patients need to wait around to see where they're going to go. But if they need to get care and it's emergent, I think people are going to do what they need to do to make, to live, right, and be healthy, right? The last bullet I had here is really cross-training and talent, because in this situation, right, if you do kind of think about that, someone could be a specialist in kind of, endoscopies, right? Or they could be a specialist in, heart surgeries or so forth. But, having cross-training of staff, anesthesiology, nurses, and others, is certainly key. I'm not saying retrain physicians, right? Or specialists, let them do their specialist thing, right? That's what they need, right? Which also could go in the model. But I think cross-training staff, because, whether you give an IV to an endo patient or you give an IV to a cardiac patient, it's the same, type of skill, knowing the processes and tools is going to challenge the physicians to train everyone, right? They're going to have to train this new staff of how to work through these things. But these were some of the key 5 things that we have implemented, and we feel that would really, be a good fit in this point, right? So I'm going to walk left to right just on here. So the first is a problem statement, right? We know it's big. The surgical capacity has declined. The capacity expansion, it's just not going to be sufficient, right, to sustain. If you think of all the backlog that they have around the world, and all the expansion, right? It's just not, there's not enough beds, right? It's just not possible, right? And if there's more, anticipated more waves of variants to come, then what, right? How does that now all the surgery centers, ambulatory centers get pushed out, right? Why not try to, optimize and turn a ambulatory or a surgery center or an outpatient into kind of like a hospital, and that it runs as much as it can, right? And then the other piece is the funding, right? The funding and care for patients is not available, which decreased health, right? If we don't do this, it's only the decrease in health is only going to get worse, right? So why not do that now to implement it, right? The next point would be kind of the problem statement. If you're bought into that, right, would be, the data and analytics. The analytics can certainly be done at the national level, but, the subnational level, meaning at the county, is key. So in a county, you may have 1 or 2 hospitals that have hospital data. They report to, the NIH and the other governments, as well as state level systems in Europe or Latin America systems where they have a system like Brazil or Mexico, right? They report into the system. So you can actually see things down to, a state or a county level to see kind of, well, how many beds are there, right? How many patients typically come? What's the backlog and so forth, right? So implementing and getting that data all the way down to the hospital level, which would include the integrated, right, ambulatory or outpatient center and surgery center would be paramount, because then you can see, okay, well, how many procedures do we have? How many beds we have? What's the staff? What's the surgical beds? Okay. What's the prioritization of procedures for where to go which, right? And then utilizing that real world data at the hospitals, you can at least run and estimate kind of, a more valid backlog and then prioritize those. Now, we're still in just the data and analytics phase, right? Where the machine learning and AI comes in is now that you have all that data, you can run an algorithm. Let's say, let's run an algorithm. Let's run a simulation, see, okay, if we have this many surgeries and let's run it this way, this way, this way, this way, and see what the optimization is. Okay, let's think about putting all GI procedures or endoscopy procedures through ambulatory. Let's think about putting, foot procedures through a surgery center, right? Or something like that, right? Let's reconsider and simulate to see kind of what works. And it's not to say that we're going to give the guide, but what's great about this is that the machine learning and AI can run it a bazillion times, faster than we can even pilot or trust, right? To see. And then, okay, hey, here's the optimal today, right? Next week, it might be different, but it's going to continue to learn through AI and then learn and make a better decision for us to kind of help patients and, improve that health from where it is declining for those things. So this is our kind of key approach that we have, and also the recommendations that, we're suggesting here is that the recommendation is that, continue with the surgical capacity expansions, right? Because I think that's the only that thing that seems like, okay, we're going to create more beds by going out, right? Okay, you have to do that. But, but if you're going to do that, implement and add machine learning and AI initiatives, right? Implement, small and large scale surgical capacity modeling, right? So what I mean by small and large scale, well, small scale could be, okay, you have one hospital in a county, right? Let's run that and see what that works, right? Or, larger scale could be, okay, let's go to Cook County, Chicago, right? How many hospitals are in Cook County? Okay, there's a handful, right? Let's run that through the model. Or, even more complex would be New York City, right? To run that through there and see, well, how many could, be seen in Manhattan versus Brooklyn and so forth, right? And all those different pieces, right? And then simulate the variety of different pieces of it where it's integrated with ambulatory and outpatient, right? Put this in the cloud, right? So that it can be in real time, real based dashboard. Everyone can see it on their phone and know what that is. So that the night before, right? Because everyone says, okay, here's where we are. What's the staff? What's the capacity tomorrow, right? You have to call those patients and say, hey, you need to show up here, here, and here, and here, right? Everyone gets the text and says, okay, I know where I need to go, right? It sounds really simple, but the technology exists that it can be done, right? We do that today for doctor's appointments, for restaurants, right? Think of OpenTable. You can do a restaurant. Why can't you do this why can't we do this for surgeries too, right? It's possible. The data is there as well. The last piece I'd say is an operations role is definitely needed in the hospital, to plan for surgeries because, typically you see today, like who's doing that today, right? You probably have the nurse manager. Nurse manager gets a list from the doctor. Nurse manager then kind of throws out those, and says this person needs to come here, right? But to get those people working out of the box, right? They need kind of some type of operations type minded person that understands healthcare, understands capacity, understands the tools. A data scientist ideally that comes in and say, let me give you the capacity modeling, right? Saying you need one for each department, no. But you could probably have two or three that kind of rotate that within a system that could at least kind of provide that guidance so that, that nurse or whoever was doing it before on the capacity or an admin or someone else kind of can say, okay, what's my list? Right, give me my list on who I need to call. Really? That's what they say, right? There might be some discretion, but, what's the other alternative? Right. I think it's a great option. Right. And, and in light of COVID, in light of some of the surgical capacity and even, supply, this could be fit. That's, I put a picture here of some of the supply that's here too as well. And hopefully people get more vaccines and we'll come out and the, things will be better overall. But in the meantime, this is our recommendation that we have for this to implement machine learning AI initiatives for hospital capacity. So, okay, perfect. So now I'm going to talk a little bit about, just switch gears around Analytics for Living. So Analytics for Living, our vision is to enable analytics for life, right? Our mission is to improve access to life-saving innovations for population of patients, right? We employ machine learning, as you heard, right, to healthcare challenges to enable access, right? Analytics for Living Foundation is a 501c3 charitable organization. So we do accept donations, right? So in this case, let's say you wanted to see, hospital capacity for beds in a particular county or something like that. Well, if you subscribe on our website, right, we'll have a kickoff call and we'll understand, okay, where do you want to see this, right? Or if you already know, you can email us and then we can have a meeting, then we'll build that for you as well to kind of get that moving. But it's definitely kind of part of our initiative to improve health. And that's where, the donations come in. Now, if it's a broader scale, right, a broader initiative, bigger system, right, we have a organization that we can form to kind of, make it more of a broader project, but it's all in the guise of kind of that foundation, because a lot of the data and the modeling and things are come from Analytics for Living. That's going to be the foundation for those analytics, right? And the last point I'm saying here is that we do offer the syndicated and consulting services there. And where Data Prime comes in, so say you need those data scientists, right, at the hospital or whoever, right? Well, Data Prime can actually, help us source. They use AI in their recruiting technology to actually pull staff and find staff for those. So, definitely a good partner to have, because it's not kind of the typical staff that you may need at a hospital, but this is a great place for that to kind of build our skills. Oops, I hit my button there. So perfect. So oops, let me go back here. Okay, so with that, thank you very much. I'll stay on the line after I cut the recording for any questions. And the call to action, I'd say for you to listen here will be one, subscribe to one of the Analytics for Living's machine learning and AI solutions. Right, we have one there on surgical demand capacity, kind of listed on the website. Right, that's kind of the piece. If you want to have a conversation first, please do. You can join, one of the scheduled, send me an invite via email, or we schedule an appointment via the online calendar, or we can, or certainly you're welcome to join in a future webinars such as this today. So thank you all for joining, and I'm going to stop the recording and I'll stay on the line for any questions.